Please see the chat for important information regarding your CE credit. Just a reminder, attendees, in order to receive your CE certificate, please be sure to complete the post-session evaluation, which will be available in your CE wallet within your TPN Health account. The evaluation will be accessible within 24 hours after the session ends. Thank you for joining us for Working with LGBTQ Plus Clients 101, presented by Dr. Jordan Westcott. My name is Jordan. I will be your moderator for the session. Dr. Jordan Westcott is an assistant professor in counselor education at the University of Tennessee, Knoxville. Her research, service, and previous practice focuses on advancing mental health equity for LGBTQ plus persons across the lifespan. She has published 19 peer-reviewed articles and participated in or led more than 40 peer-reviewed conferences at international, national, regional, and state levels. She has a long history of leadership and advocacy in the mental health profession, resulting in leading national committees, winning awards at the national level, and serving LGBTQ plus and counseling organizations in other capacities. On behalf of the TPN Health team, I'd like to say a big thank you to Dr. Jordan Westcott. And at this point, I'm going to pass things over to Clinical Outreach Manager of Sandstone Care, Deb Lawton, and you can go ahead and take things away.
All right, thanks, Jordan. So my name is Deborah Lawton. I'm a therapist, and I'm also a clinical outreach manager at Sandstone Care. I'm so glad you are joining us today for this Working with LGBTQ Plus Clients 101. As Dr. Westcott was saying before we joined, it's a super important topic, especially right now, as I know you all are aware. So in case you're not already familiar with Sandstone Care, we provide a full continuum of care for mental health, substance use or dual diagnosis treatment, primarily for teens and young adults, so ages 13 through 30. And we have one program that is for adults 18 and up with no cap on the age. So the continuum includes teen and young adult residential treatment, both for dual diagnosis or primary substance, and one for mental health. And we also have IOP and PHP, same ages, 13 through 30. And then we have an adult detox or withdrawal management, and it's also a short-term residential, and that is the program we offer for adults 18 and up. We have locations throughout Maryland, Virginia, Illinois, and Colorado, and our residential facilities, we get clients from all over the U.S. Sandstone is in network with most major insurance carriers, including TRICARE and Kaiser. Happy to talk more offline about our services and your needs. I'm going to put some information in the chat for your reference, as well as my contact information. So, and now, without further ado, here is Dr. Westcott. I hope it's helpful for you.
Hi, all. Thank you so much for having me. I'm sure you saw in the chat, but I'll just say it verbally as well. Please use the Q&A function if you have questions as we go. It's really important to me that I answer your questions. So I've designed this to be a kind of comprehensive basic primer for how you can work with queer and trans clients, with a particular focus on adolescence and that emerging adulthood period that Sandstone Care primarily serves. And so I hope that this is useful for you, and I will go ahead and share my screen and we will get started. But again, I'll keep an eye on the Q&A, so please feel free to drop in questions at any time. And I invite Jordan and Deb, if I haven't answered a Q&A, but I'm moving to the next slide, to pause me. If questions are in the chat, they might get lost. So please make sure that you're using the Q&A rather than the chat so that I can see it. All right, can folks see the slides specifically? I might ask Deb to nod so that I can tell if the slides are what's visible. Okay, perfect. So you can see I have a much longer acronym. I work with SAGE, which is the ACA division focused on LGBT counseling, and that's the initialism that they use. But throughout the presentation, I will primarily say LGBTQ plus and or queer and trans as umbrella terms, and we'll talk a little bit more about why in just a moment. So you can see our learning objectives here on the screen. They align with what you signed up to learn, so I won't read them specifically, but I will highlight. My hope is that you walk away better understanding how to recognize when somebody might be at risk of a mental health condition or substance use, so understanding the risk factors and the protective factors that you can tap into as a clinician. And then I also hope that you will be able to use specific strategies to integrate more LGBTQ affirming care into your work, and then use some strategies to think about the context that people are working from. Because when you're working with adolescents, younger people, and emerging adults, frequently their family context and other components are really, really important in the care that we provide. So we're going to spend a little bit of time today talking through orienting language, making sure we're all on the same page about what different language means. Language is very important when we're thinking about engaging in LGBTQ plus affirming care. We're going to talk about mental health and substance use among LGBTQ persons with, again, a specific lens on what do we see generally, and then narrowing our focus in a little bit to adolescents. And then we also will talk about specific strategies, how we can support folks in their families and context, and then hopefully have a little bit of time at the end for additional questions, concerns, follow-up that folks might want to take. So we will start with orienting language, so the terminology and vocabulary that we're going to have a shared understanding of during our time together today. And I think it's really important to start with, like, what do we mean when we say LGBTQ+? This is a big umbrella term for a lot of different identities that really emphasize people who are not heterosexual or cisgender. So people who do not fit into what our society has decided are the dominant identity cultures. So LGBT stands for lesbian, gay, bisexual, transgender, queer, or questioning. But we also have broader initialism to include intersex, asexual or aromantic people, and other people who are sexual and gender minorities, meaning that their sexual orientation or gender identity is minoritized in our broader culture. So a sexual or gender minority, again, is essentially saying that the social forces around us treat it as different or minoritize it in some way. So this is things like most of the structures around us are designed for people who are in opposite gender relationships. We didn't actually have access nationally to same gender marriage until 2015. And so there are specific legal and political ways that LGBT identity has been minoritized, similarly with gender identity. Sexual orientation refers to an inherent or unchangeable, enduring emotional, romantic, and/or sexual attraction to people of different genders. So this is important to highlight because it is not changeable. All of the research that we have tells us that sexual orientation change efforts do not actually change somebody's innate sense of attraction, whether it's, again, emotional, romantic, sexual, or combinations therein, but it does lead to worse mental health outcomes. So when I am teaching people about this, the most important thing that I want them to walk away with in terms of understanding these terms is to know that these are not decisions that people made, and it is not possible to change somebody's sexual orientation or gender identity through therapeutic efforts or other efforts. Similarly, gender identity is instead an internal experience of gender. So a person's sense of being a man, a woman, a blend of both, or neither. So this is different than the sex that somebody has been assigned at birth. So when we're born, somebody looks at us externally, looks at our genitalia and says, I think this is a boy, or I think this is a girl, and we are assigned a sex at birth. And our innate sense of gender is more how we experience ourselves and who we are. For most people in the world, I think that it's, like 98% of people, their sex assigned at birth aligns with their gender identity, so they're cisgender. But for transgender people, that innate sense of gender is distinct or different from the sex that was assigned at birth. There's also some complicated components when we get into intersex identities. So people who do not fit neatly into the binary sex categories that we assign. This may be because of chromosomal differences, differences in secondary sex characteristics, differences in how the body processes hormones, even differences in having like visual differences to genitalia. And some intersex people, therefore, do identify within the LGBT community, whereas other intersex people may not identify within the LGBT community. We'll get into some more of this nuance as we keep moving, but I think it's just a helpful primer to think about who are we talking about and what do we mean with some of this language. A final point that I have as we think about understanding the terms is that sexual orientation is not the same thing as gender identity. They're sometimes conflated, and I understand why we use an umbrella term to describe the whole community of LGBT, but we have to recognize that sexual orientation and gender identity are different things. And so being able to differentiate those things helps us better understand the experiences that people are having. And I will enable closed caption on the next slide so that we've got that going. And for some reason, I can't have the slides up and access the Q&A. It like makes it disappear. So I'll just invite Jordan, if you don't mind letting me know if there are questions in the chat as we transition between slides. That way I can answer any questions as they come up. All right, so again, some orienting terminology. These are just definitions to make sure we're on the same page. I'm not going to necessarily need to read each one of these, but I want to highlight them. So lesbian or gay most often refers to a man or a woman who are exclusively attracted to people of the same or similar genders. I say the same or similar because, for example, you get into some nuance when you layer on gender identity. So I'm a lesbian. I'm a cisgender woman, and I am married to a non-binary person who also identifies as a lesbian. So they don't identify as a woman, they don't identify as a man, but because of how they were socialized and how they came to understand themselves as a person, lesbian is the label that works for them. So I sometimes think of being a lesbian as being a non-man also attracted to non-men, right? So there's some nuance here when we start to think about how these things intersect. Bisexual refers to a person who experiences attraction to two or more genders. Other terms that people use for this type of attraction might include pansexual. So for some folks, pansexual fits better. The term bi might feel like you can only be attracted to two genders, and it doesn't feel as inclusive to trans people for some people. The original definition of bisexual was always inclusive of two or more genders. Cisgender is for those of us for whom our innate sense of gender identity aligns with the sex that we were assigned at birth, whereas transgender would be for those of us for whom our innate sense of gender identity does not align or is different from the sex that we were assigned at birth. We also just use the term non-binary. So that's a person who doesn't identify as a man or a woman. So it might be both, it might be neither, it might be somewhere in between. And it's often used as an umbrella term that encompasses many different experiences of gender identity. So other language you might hear for folks who fall under that umbrella might be genderqueer or gender fluid or agender, where there's some more specific identity labels that people can use to describe their experiences. We also have queer, which is used largely as an umbrella term. It did used to be a slur. It's been reclaimed by the community. It's used in academic study contexts, which is really just any person who is not exclusively attracted to someone of the so-called opposite gender, i.e. anyone who's not straight, anyone who's not heterosexual. The term queer can be an umbrella term for that community. Whereas straight or heterosexual refers to somebody who's exclusively attracted to someone of the opposite gender. And there are additional terms that might come up as we're talking today. And so if you do have questions about any of the language I'm using, please feel free to ask. I'm happy to answer those questions. I think it's really important that we're on the same page about it.
We have some questions in the chat.
Yeah.
All right, the first one's from Andy. I have a new younger teen client who is trans. I'm seeking Maryland resources for him and his parents. Meet other, sorry, Parents really need to meet others going through what they are now.
It's a really good question. So I don't know if you're connected at all with any of the local PFLAG groups in your community, but PFLAG is for parents, and it was originally for parents of gay and lesbian children, but they're very expansive. They include transgender children. PFLAG is going to be like the #1 support wherever you are for affirming parents who really want to support their kids but need other people around them. I actually also recommend PFLAG when you're working with kiddos whose parents are disaffirming as a starting place. Often other parents are the best resource for helping them get on board with supporting their kids. There's also the Maryland Counseling Association. They are very pro-LGBT and would know the local resources even better than I would, and might be a really excellent connecting place as a start. So I would look for PFLAG chapters. I would look for any of the Maryland Equality Centers. I know there's a couple of pro-LGBT organizations in Maryland that would know the PFLAG chapters. And then the Maryland Counseling Association is really, really actively involved with supporting LGBTQ plus counseling and might be an excellent resource for kind of getting connected more locally. Great question.
All right, thank you. We have another question from Nidhi. You might be covering this, but my main question is regarding, given everything happening in many legislations ending gender affirming care, folks are seeking letters for HRT/gender affirming procedures. However, they don't meet WPATH standards or are asking for letters within the same week. What do you recommend or suggest? The best way to meet clients' needs right now? Thank you.
Yeah, that's hard. So when we get into some of the strategies, I don't have a specific slide, but I'll jot down a note to bring in the letter writing component when we get into the LGBTQ plus affirming care broadly conversation, because I do think that that letter component is really, really important. And I get the urgency that folks feel right now to access services when there's a chance that they'll be gone soon. So I'll make sure to cover that a little bit more when we get into those strategies. Thank you. Good questions. Okay, not hearing more, we'll move forward. So this is one of my favorite visualizations. I use it with my students, I've used it with clients, I've used it with parents when they were trying to understand like what their kids were experiencing, for understanding the difference between gender identity, sexual orientation, and then how somebody presents to the world. So the Gender Unicorn was developed by the Trans Student Educational Resource Center. There's a link available on this slide. You can see it right here, transstudent.org/gender. And so gender identity, as you can see, it's this little rainbow, and that is a person's felt sense of being a woman or girl, a man or boy, or another gender. And that is distinct from the sex that somebody might have been assigned at birth. So those chromosomal pieces and the physical sex characteristics that we see, so female, male, or other intersex. Just because somebody has a specific gender identity or sex assigned at birth does not mean that their gender expression has to align with what we see. So somebody can be, for example, non-binary and present femininely, masculinely, or both, or more androgynously. So the way we present our gender to the world does not mean that we have to align with a specific gender identity. So I use myself as an example because it's easy. So I'm a cisgender woman. I think I present pretty femininely. I have long hair, I wear makeup. Whereas I've known other cisgender women who present more butch, so keep a very short haircut, don't really wear makeup, wear clothing that we traditionally associate more with masculine presentations. And that does not mean that that person's a transgender man. She's still a woman, but presenting in a way that aligns more with how she experiences her own gender. And that's distinct from this sense of attraction, so that physical or emotional attraction. It's just really helpful in helping people see the difference between all of these constructs and remembering that just because somebody identifies as a certain gender does not mean that they have to present in the stereotypical ways that we associate with that gender presentation in our culture.
All right, we have a couple questions.
All right.
First one's from Brad. What is HRT and WPATH?
Good question. HRT is hormone replacement therapy. So that's specifically for people trying to access hormones to support them living as the gender that they are. And so when we're talking about youth and adolescents, we're getting into the weeds a little bit, but I don't mind, I like it. When we're talking about youth and adolescents, HRT is most often a puberty blocker, meaning that we are preventing somebody from experiencing the full scope of puberty and allowing them to pause the development of secondary sex characteristics. Infrequently, when we're talking about people under the age of 18, that might actually be what we call so-called cross-sex hormones. So somebody who was assigned female at birth accessing testosterone, or somebody who was assigned male at birth accessing estrogen and progesterone. Again, that's actually not very common before the age of 18. Most often what we're seeing are people having access to puberty blockers, which are safe and reversible. Puberty blockers were actually developed initially for cisgender children experiencing precocious puberty, meaning that they started puberty earlier than they should have. And it was a medical way to pause that puberty until it was developmentally appropriate for them to go through it. And so now it can also be used to support gender affirming care. And in many cases, particularly if folks are concerned that somebody might not actually know who they are yet, like children are going through stages of identity development, a puberty blocker is one of the best options, because if they are trans, they have not had to go through a puberty that will increase a felt sense of dysphoria, which is deep distress related to one's body not aligning with a gender identity. And instead, they have kind of time to pause and experience and socially transition, and then decide if they want to be on hormones longer term. So they're completely reversible, very safe. Lots of studies have been done on it. So that's what HRT is. And WPATH is the organization that supports transgender health. It's a worldwide organization, and they have really excellent clinical guidelines for how people can engage in gender affirming care.
Thank you. And the next question is from Sean. I have a new client, 18 years old, who is not attracted to any gender. parents are concerned and not sure how to approach the situation, any information or resources would be helpful.
Yeah, so that is asexuality or aromanticism. So somebody who does not experience a felt sense of attraction. Asexuality exists on the spectrum, and so they may never experience attraction, or they may experience attraction only in certain kinds of relationships. I don't know that within the scope of this presentation, within keeping an eye on time, that I can get into all of the clinical nuances of how to support, but I will say maybe the most helpful thing is to help them understand that that's a valid identity and a valid experience, and it doesn't mean that something is wrong with their child. The same way that somebody being attracted to people of the same gender or many genders doesn't mean that there's something wrong. Not experiencing that attraction does not mean that there's something wrong. It often is just an experience that people are having. And so there are some really great resources out there. I would encourage you to look into some of the asexuality organizations. If you start with some of those ACE spectrum is often what they call themselves. That would be a really great place to get some resources. And you're also welcome to reach out and I can share some specific links if that would be helpful.
All right, thank you.
Okay. So as we're talking about language, I do just want to highlight that not one size fits all, right? So I'm using some broad umbrella terms today. And as you're already hearing in the chat, there's like different, or in the questions, there's different ways that people identify themselves and talk about themselves. And so different individuals have different preferences regarding language, and some of the factors that influence what language an individual person might use for themselves will differ based on different cultural experiences. So there's age, so preference for among older people, for example, there is language that younger people might consider outdated, but that's the language that they found for that they kind of came of age with. So for example, we don't use the term transsexual anymore broadly to describe trans people. It's considered harmful to use that as an umbrella term, but some individual trans older adults might still use that term to describe themselves because that was the term that was being used as they came into understanding who they are. Same thing with, we don't tend to use homosexual anymore, and we'll talk a little bit more about why later on. But there might be some older adults who use that term. Racial identity can also influence how people identify. So we might have same gender loving among Black older adults specifically. The first language that somebody uses might also influence what kind of language works. So you'll see, like in some of the efforts that we've had for making more inclusive language, Latinx came up, but then people who spoke Spanish and were from those cultures were like, that's actually like not pronounceable in Spanish. And so there was a preference for Latine, which is the E can be the gender neutral add-on to the end of that word. Region or location. So in the Southern US, we might see some different references to queerness rather than other places, and even held identity. So I named before, like a non-binary person who is not a woman might still identify as a lesbian. And so the main thing I want you to take away from this is I'm giving you definitions and terminology. And I think it's really important to explore what language feels most accurate to the individual client that you're working with, or when you're working with adolescents, sometimes in school context, student that you're working with, and use that language for them, even as you use this more inclusive language to describe the community as a whole.
We have a question
Yeah.
from Gina. What term do we use instead of homosexual, and when did that change?
So we use either gay, lesbian, or some people like the term queer. And we're going to talk a little bit about how and why that changed over time in just a few slides as we get into some of the historical context. So if you're okay with it, I'm going to answer that question a little later on because it's built in to kind of help you see how our field of psychology, social work, counseling actually has been a part of where the historical harm has come to for this culture. Okay, so just some additional terminology. These are terms to describe the types of discrimination that LGBTQ people might experience. And so heterosexism is a system of attitudes, bias, and discrimination that is in favor of heterosexuality and heterosexual relationships. We have cissexism, which is similarly a system of attitudes, bias, and discrimination in favor of cisgender identity and traditional gender roles. Heteronormativity is this idea that heterosexuality is the standard or the norm, and that people should conform to traditional gender roles and relationships. And the reason I like to use these terms instead of homophobia or transphobia is because this is a system of oppression, and it is not necessarily based in fear. When we use a term like homophobia or transphobia, which many people, many queer and trans people choose to use that language to describe their experiences, so they're not wrong, but this is when I think about how I like to situate it. The implication is that people are afraid, and so maybe it's okay that they engage the way that they do, or that it's okay to discriminate. And so I think situating this within systems of power is very, very important, and recognizing that individual manifestations are coming from institutional power that disproportionately impact LGBTQ folks. And so within that, as we're navigating this world and experiencing these things all the time, we internalize the stigma that we encounter. So internalized stigma about and negative biases about one's own minoritized sexual identity or gender identity is often a clinical issue that you'll be working with when you support LGBTQ plus clients. And so it was important to me just to highlight, these things are really important, and you can use homophobia or transphobia if you want to, but I think it is worth situating these things within the systems of power from which they come. And again, I know I keep repeating this, but it feels really important. So a final note about language: umbrella terms don't align for everyone. So you hear me alternating between LGBTQ plus and queer and trans. Not every person who is LGBTQ identifies as queer. And so I might use the term queer and trans to describe the community as an umbrella, while recognizing that I would not describe an individual person who identifies as gay and doesn't like the term queer. I would not refer to them as a queer person at the individual level. So how we refer to a group is not always the same way that we refer to the individual person. And another piece, since we are talking some about adolescents and emerging adults, younger LGBTQ plus people tend to have more specific and nuanced labels for multiple aspects of experience relative to older LGBTQ plus people. And so younger generations, essentially what happens for queer and trans people is, for a long time, how we were allowed to describe ourselves was dictated externally. And they were labels put on us frequently from medical providers, psychological care providers, and legal and carceral systems that defined who we are. And as social acceptance has increased and communities have gained more power and had the opportunity to describe for ourselves who we are, we've gotten more nuanced labels. But those labels sometimes confuse people. And so it's just worth highlighting, if you're working with younger folks, you might think about how language is very different for some of them. So one clear example is something called neopronouns. Neopronouns are for people who don't identify as a man or a woman. There might be pronouns that don't fall into the traditional structure. So it's not she, her, he, him, or they, them, but things like z, zir, or fey person. There are really creative different ways that people use pronouns outside of what we traditionally associate with men, women, or groups of people, or a person whose gender we don't know. Some people also use it or its pronouns, and that can sometimes make clinicians feel uncomfortable because they feel like they're dehumanizing that person. But if that's the language that they use for themselves, it's not dehumanizing for them, even if, or for that individual, even if I would not use that for any other group of people. Similarly, there are some intersections with other salient identities that sometimes lead to more nuanced labels for one's gender or sexual orientation. So an emerging way that younger people who are neurodivergent, specifically autistic, are defining themselves is through this term autigender, which is relating to how autism and gender feel inextricably linked for some individuals. And so it's really important that there may be things you don't understand. As a queer person myself working with this population, when I get to learn about something new, there's things I don't know that by working with younger LGBTQ plus people, I get to learn about. And so it's important for us to remain open and curious, even when we don't understand, and invite people to help us understand so that we can then go and do our own research. So before we transition into some of the statistics of what impacts folks, I did just want to name who are LGBTQ people in the United States, now that we're kind of on the same page about the language we're using. So roughly 9.5% of adults in the United States identify as LGBTQ. And we do see that most of these folks identify as bisexual. So a little over half identify as bisexual of that group. So it's like 5.2% of the overall population, but 56% of LGBTQ adults in general. And we see the proportion of people in the United States who are identifying as LGBTQ plus are increasing over time. And we see the largest proportion of increase among younger generations. So roughly 14% of millennials identify as LGBTQ, and roughly 23% of Generation Z identify as LGBTQ. So that's almost 1 in 4 individuals in Generation Z. LGBTQ identification among older groups is increasing, but it's slower. It's a couple percentage points per year rather than the kind of more marked increases we saw with younger people. I highlight this to say that there's evidence that this is actually related to greater social acceptance rather than a social contagion, which is sometimes what people claim. So it's not that someone hears that someone else is LGBT and thinks it's cool and decides, I want to do that. It's instead whenever people do not have social stigma attached to whether or not being LGBT is a good or bad thing, they're able to explore more openly and realize who they are earlier. So I don't know if anyone here has ever seen that chart of like left-handedness in the United States, but it's really, really low. And then the year that we kind of stop, for example, tying people's hand behind their back so they have to become right-handed, we see a sharp increase and then it levels out at about 11% of the population. There's a lot of evidence that that's what's happening here. So it's not that we're just starting to see maybe the truer proportion of who identifies as LGBT as we've seen social stigma decrease related to these identities. And it's probably going to level out at a certain point. All right, so we're transitioning into talking about mental health and substance use. I will briefly pause to see if there are any other questions about language, terminology, identity before we transition into talking about mental health and substance use specifically.
Yeah, we have one from Janet. What does androgynous mean? Have you seen a lot of autistic as being transgender? Have you heard of the double rainbow?
Yeah, great question. So androgynous refers to a gender presentation. So it's not an identity, but it's the way that you present your gender to the world that isn't masculine or feminine. So it sometimes looks like putting things that we traditionally associate with masculinity or femininity together to create a look that fits kind of in neither category neatly. Or it can often look like if you are somebody who's frequently read as feminine, adding masculine presentation to your appearance in a way that makes you kind of look like neither. So androgynous presentation is just about finding a gender presentation or expression that's in the middle. The second piece that I think I heard you asking about was the intersection between autism and gender identity and the double rainbow. And yes, absolutely. We need more research, but there is evidence to suggest that autistic people are more, and I use autistic people on purpose. So I know that there's often a conversation about identity first versus person first language related to disability. In general, the autistic community as a group, right? So not every individual person has named that they prefer the term autistic identity first language. And so that's why I use it that way. But autistic people, there is some evidence that there is a higher proportion of autistic people who are transgender than of non-autistic people or neurotypical people who are transgender. And we don't quite know why that is yet. I imagine it might have to do with if somebody already doesn't fit into the neurotypical and stereotypical social standards, there's more permission to explore gender identity and have an awareness of whether or not your gender identity actually aligns with the sex that you were assigned at birth. But we need more research. But I am aware of the ways that autism and trans and non-binary identities intersect in a way that like really helps people authentically be themselves. And it's really exciting to see.
All right, thank you. We have another question from Sandra. Would androgyny be similar to non-binary?
Good question. And I totally see how you're thinking about that. So I'm going to go back to the gender unicorn for just a second. So non-binary has to do with gender identity, right? Like who I am inside. And androgyny is gender expression. So it's different. So you can be a woman, a man, or someone of any other gender and present your gender androgynously, because that has to do with how you present your expression to the world. Similarly, you can be non-binary and actually still present in a very feminine way or a very masculine way. And so frequently we see people who are non-binary having a more androgynous gender expression because that aligns more with that innate sense of gender. And you do not have to be a non-binary person to present androgynously, and non-binary people do not always present androgynously. So there's definitely a correlation there in terms of how identity is expressed externally, but it's more about androgyny being how do I present myself to the world in a way that isn't masculine or feminine, whereas non-binary identity has more to do with who am I and how do I feel that inside. Really, really good question.
All right, thank you. That's all the questions on language and terminology.
Great. Okay, so let's talk a little bit about mental health and substance use. And so I told y'all I'd get back to this language component. So I want to give a brief history as we think about how we engage with queer and trans folks as clinicians. So the reason we don't use homosexuality anymore is because the term homosexual referred to a mental health disorder in the DSM. And so homosexuality was in the DSM from 1952 to about 1974. And actually, it was in there as a sociopathic personality disorder. So it was a very stigmatized, very pathologizing diagnosis. And so people tend to think that, like, oh, well, homosexuality was removed from the DSM in the 1970s. And while that might, like, it was removed as a sociopathic personality disorder, actually distress over one's own sexual orientation remained in the DSM under different names until the DSM-5 in 2013. So there was still a diagnostic code to bill for to support sexual orientation change efforts. Similarly, research on queer and trans people was used to reinforce negative stereotypes and focused on populations that aren't representative of the population. So most of the research that was happening on LGBTQ people in the 70s and 80s was focused on incarcerated populations and focused on people or clinical populations. And so all of the research that was coming out was saying, well, these are bad people and really pathologizing. Simultaneously, any intervention research that we had going on was focused on how we can change somebody's sexual orientation up into the 21st century. And then gender identity change efforts have been accepted even longer. It is still considered acceptable by some clinicians in a way that sexual orientation change efforts aren't. But both of these things persist today. And actually, there is a case being reviewed by the Supreme Court right now in 2025, where a Colorado therapist is suing and saying that Colorado's law banning conversion therapy or sexual orientation change therapy violates her First Amendment rights. So this is debated legally, but not in the research. The research shows that sexual orientation change efforts increase suicide ideation and do not actually change somebody's sexual orientation. And the same thing is true for gender identity. Additionally, gender dysphoria, which is a diagnostic code for transgender people, remains in the DSM-5 up to today. That does position transgender identity as potentially problematic. However, this also is to ensure access, because for transgender people, often there is a need to access medical care. And you need a diagnostic code for insurance to cover that medical care or gender affirming care. And so the shift to gender dysphoria has kind of named that, like, there is nothing wrong with this person. And to treat their dysphoria, we need to give them access to the interventions that help them live their life as who they are. But so that's just some of the history and context as we step into thinking about mental health and substance use disparities for this population. So sexual minority people, these are looking at some statistics from 2023. So sexual minority people were more likely to have any illicit substance use and a diagnosed substance use disorder in the past year than straight people. And bisexuals and men were at higher risk than people who identified as gay or lesbian, and than women were in general. Similarly, sexual minority adults were more likely to have any mental illness in the past year and a serious mental illness than were straight adults. And we see something similar in that there was an elevated risk for bisexual individuals, but women were more at risk in this category than men were. And transgender adults report higher suicidality, higher mental health distress, and greater substance use than cisgender adults do. And non-binary people are at the highest risk within those categories. So we see some disparities between the general population and specifically compared to heterosexual and cisgender individuals related to substance use and mental health concerns. This is also evident in adolescents and younger adults. So LGBTQ youth, and we're specifically looking here at people aged like 12 to 17, are 4 times as likely as their heterosexual cisgender peers to attempt suicide, and nearly 20% of queer and trans youth reported a suicide attempt in 2021. So that's 1 in 5. Queer and trans younger people also report experiencing higher rates of sexual violence than does the general population. So roughly half aged 13 to 18 versus about 11% of the general population. I do want to add a note here. We're going to get into why in a second, but I want to highlight that this is not, they're not like necessarily more likely to experience these assaults because of risky behavior on their end. They're more likely to be targeted, in part because of how our society isolates LGBTQ plus adolescents. So it is not that being queer or trans like is bad and makes you more likely to have these experiences. It's that the way that our society marginalizes these experiences makes people more vulnerable to abuse. And that's just an important caveat to include. More than half of queer and trans young people who wanted access to mental health care in 2022 were not able to access it. So they wanted to get care, they needed support, and they couldn't get it. And about 28% of queer and trans youth experience homelessness or housing instability at some point in their lives, frequently because they're kicked out by their parents when they come out. The queer and trans youth who do experience homelessness or housing instability are 2 to 4 times more likely to report depression, anxiety, suicide ideation and attempts, and self-harm than people who do not, than LGBTQ youth who do not experience homelessness or housing instability. So there's some really serious pockets of risk, particularly for queer and trans younger people, that we need to be aware of. So again, I already previewed this a little bit, but I think it's important to recognize that just because we see these disparate health outcomes does not mean that being an LGBTQ person is an inherently sad thing. And these disparate health outcomes are not because of someone's sexual orientation or gender identity, but because of how the world responds and how the world is situated around people with diverse sexual orientation and gender identities. So minority stress theory was developed by Meyer in the 1990s. That was kind of a shift from the research context that I was talking about at the start in the 70s and 80s, where he was like, well, let's look at social stress theory and actually look at minority stressors. And so we have distal stressors, which are these external social things. So things like, we'll talk more about specific ones in a minute, but things like moving through the world and experiencing discrimination is a stressor, or being rejected based on your LGBTQ identity, that's a stressor. And then when you're exposed to those external stressors enough times, you start to expect it might happen, and you start to have internal stressors as you figure out how to navigate the social context that you're moving through. So these minority stress processes, there is exposure to these external objective stressors. So these can be both acute individual experiences and chronic. Things, again, discrimination, housing or job, employment, healthcare discrimination. It might be individual experiences with prejudice. So somebody assaulting you or harassing you or demeaning you based on your sexual orientation or gender identity, bullying when we're looking at younger people. And you're having this exposure frequently to these external stressors. And so then you start to expect them. You start to like be on the lookout for the ways that the world is going to respond negatively to you based on your sexual orientation or gender identity. So we have these expectations of discrimination or rejection, and that also then leads to hypervigilance, right? We're kind of worried about, oh my gosh, this bad thing is about to happen. And now you have higher cortisol, you're carrying a higher allostatic load, and your nervous system is constantly dysregulated as you anticipate these social stressors. As you're navigating the world, you're being externally exposed, you're now anticipating them all the time and living in a pretty chronic state of nervous system dysregulation. You then start to internalize the negative stereotypes and bias that you hear about your minority identity in the culture around you. So when you think about depictions of LGBTQ people in the media, the stories that we hear about queer and trans identities in the news, ways that you hear your church or your parents or your friends talking about these identities, you start to internalize those negative stereotypes as a part of the hypervigilance. And so those are the things that lead to the disparate health outcomes that we've been talking about. So the specific stressors that we see, those internal stressors that we develop in response to the external stress that we're constantly navigating, expectations of rejection. So I think people are going to reject me. Humans are social animals. We need connection. We need one another. And so walking around with this felt sense of, if you knew the real me, if you knew this thing about me, you would reject me. You would not want relationship with me. You might even hurt me. That's a lot to manage in one's own mind. We also have identity concealment, which means not disclosing one's sexual orientation or gender identity. So because you're afraid of discrimination or you're afraid of that rejection or it's legitimately unsafe. And so you're having to put a lot of cognitive resources into bracketing that part of yourself and making sure that it doesn't come out. And then through those things, you're still getting exposed to the negative stereotypes and stressors. And so you internalize stigma related to your identity. And so then later we kind of were like, okay, well, how does this lead to worse health outcomes? And so we have the psychological mediation framework, which kind of shows you're experiencing these external stressors, you're kind of walking through stigma, and that stigma layers on top of the daily stressors experienced by all people. And then that eventually leads you to have exposure to those internal stressors because you're psychologically, you're trying to make sense of the world, you're trying to keep yourself safe, and you develop these internal proximal stressors. And then these psychological processes mediate the relationship between these external stressors you're experiencing and health outcomes. So things like being hypervigilant eventually looks like an anxiety disorder. This is a form of trauma. Or when you're constantly expecting that you're going to be rejected and that people won't want you, that can contribute to suicide ideation. So the whole idea behind this essentially is that these disparate health outcomes are not because being LGBT is inherently bad or because it's an inherently sad experience. Instead, it's that the social stressors are what lead to the poor health outcomes that we see and that we just described on those previous slides. We're about to talk briefly about some of the unique components for gender identity and trans folks, but I'm going to pause and see if there were any questions about minority stress theory before we move forward.
There's no questions on minority stress theory.
All right, then we'll keep on moving. So gender minority stress theory applies that minority stress framework to gender minority people specifically. So there are some unique distal stressors related. So the external stressors are gender-related discrimination. So it's not just related to sexual orientation, but it's specific to how you're presenting your gender and your gender not aligning with the sex assigned at birth. There's also gender-related rejection. But another unique component that queer people don't tend to experience is a non-affirmation of gender identity. So refusing to use someone's pronouns or refusing to use someone's chosen name or insisting that someone is the gender, like is the sex that they were assigned at birth instead of the gender that they're telling you. So that is another external stressor that is unique and specific to transgender and non-binary people. There are also unique proximal stressors. So that internalized cissexism, this idea that like I have negative stereotypes about gender identity that have been internalized, negative expectations of what it will be like to move through the world, and identity concealment. So there's some relatedness to what we see for the broader minority stress theory. So within that, we have some specific risk factors that tie on to minority stress theory. So this is some evidence from the literature that this is accurate. But that also you can keep an eye out for when you're working with LGBTQ plus persons to better understand what factors might make them more likely to either have a mental health disorder or a substance use disorder, or to have a more severe presentation of those things. So these are things that I would assess if I were working with an LGBTQ adult in the community. So first, lifetime experiences of discrimination. So people might right now be in a context where they're not experiencing very much discrimination, but those past experiences that they may have had with discrimination have accumulation effects over the life course that lead to worse health outcomes. Within that, there's then current experiences of discrimination. So somebody might have had past experiences, and then if they're having current experiences where they're being discriminated against, and this can happen in a wide array of places where we really see things happening frequently according to the literature. Up before 2024, I would say, I think things are shifting right now. Were things like employment discrimination, so being fired or not hired or passed over for a promotion, housing discrimination, so not people choosing not to rent to you or not to sell to you when they realize that you're an LGBTQ person. We see healthcare discrimination where folks provide worse healthcare or are unwilling to work with you based on your LGBTQ identity. And there are many states in the last 4 years that have passed laws and ordinances allowing medical providers to discriminate against LGBTQ people on the basis of sincerely held religious beliefs. But you also might see this in other contexts. Anywhere where discrimination can happen, it happens to queer and trans people. It's also important when we're thinking about adults to think about historical experiences of family rejection as well as current family relationships. One of the largest predictors of worse health outcomes for queer and trans people is family rejection, both at the time that that occurred, but also if it happened to that person in the past. So understanding how a family reacted when somebody came out and how the relationship has changed over time. As with all people, past trauma is a risk factor for mental health, and queer and trans people are more likely to have experienced trauma than are the general population. Some of it is LGBTQ plus specific, and some of it is, again, that process I was talking about before, when if our society marginalizes you, you are more likely to be targeted by people who want to hurt you because you have fewer resources to help keep you safe. So it has more to do with how our social processes isolate people than LGBTQ identity specifically. And then finally, there's some really, really salient evidence out there that when anti-LGBTQ plus policies pass, whether that is legislative at the federal and state level or within institutions or workplaces, we see bad outcomes for people's mental health. So in places where there are laws that inhibit LGBTQ persons' civil rights, you are more likely to see worse mental health outcomes. And so it's really important for you to be aware of the context in which you're operating. This ties in a little bit with some of the questions about letters. So when we talk about the LGBTQ plus youth and adolescent specific risk factors on the next slide, I'll make sure to come back to that question about writing letters and folks getting access to HRT and other forms of gender affirming care. Doing a quick pause to see if there were questions. So when we're thinking about youth and adolescents, there are some pretty specific, unique risk factors that are worth assessing for. Again, the number one thing that we see in the literature is family rejection. We need our families. We're social animals, and the family system is where youth and adolescents are learning how to make sense of the world, and is supposed to be the safe landing spot as they navigate that identity versus role confusion experience that they might be having. So when your family rejects you entirely or rejects that part of who you are and that experience, it's quite harmful to folks' mental health. So recognizing that rejection can look lots of different ways. So you heard some examples before about homelessness can occur because LGBTQ youth are being kicked out of their homes once they come out. That's one way that rejection can look. That's one of the more extreme examples. But rejection can also look like you're still allowed to live in the home, but I've withdrawn relationship. And so I don't talk to you the same way that I used to, or I no longer show you affection as your parent. It can look like saying, this is just a phase, I don't believe you, this isn't real, refusing to use someone's name or pronouns, speaking poorly about their LGBT identity, things like that. So we're looking for some of those concerns when we're working with youth and adolescents, particularly because they are actively in that system in a way that adults are not most of the time. Bullying is also a pretty specific risk factor. So we know that estimates range between like 50 and 70% of LGBT youth in the United States report that they've experienced bullying at school based on their sexual orientation or gender identity. That's a quite high prevalence relative to the general population regarding just experiencing bullying in general. And bullying has relationships with suicide risk, depression, anxiety, and self-harm. So making sure that when you're working with LGBTQ youth and adolescents, you're assessing for bullying experiences. It can be verbal, it can be physical, it can be like more social and environmental, some of those like exclusion factors rather than someone calling them names. And all of those things have really, really negative effects on LGBTQ youth's mental health. We also see experiences with discrimination. So things like not being allowed to play on the sports team that aligns with your gender identity, or not being allowed to take part in a club because people are uncomfortable with your LGBTQ identity. A really salient example from some of the work that I've done is I think about, gosh, this was back in like 2020 or 2021. It was a national story at the time. There was a school in Virginia that was doing a school shooter drill, which I have feelings about that are separate from this. And so the procedure was that children would go in the locker rooms to be safe. And there was a transgender girl at that school, the only transgender student at the school. And they couldn't decide, even though they were not using the locker room for sports related things, no one was going to be changing clothes. They were just going to be in there to be safe from this hypothetical school shooter in practice. They couldn't decide which locker room she was allowed to go in. And so they left her in the hallway during the school shooting drill. And what that communicated to her was that they would not keep her safe if something like that happened in her school. She would be left and unprotected when every other student in the school had a safe place to go. So that's a really clear example of discrimination and how what that communicates to that person creates really, really bad mental health outcomes. We also see social isolation. So this kind of ties in with the bullying piece, but when people are socially isolated, we just tend to see worse mental health outcomes. And so social isolation can occur because LGBTQ plus youth are being bullied or being isolated based on their identity, but it can also occur as a part of that identity concealment process through minority stress. So people might say, if I'm close to anyone, they'll know this thing about me and they won't like me anymore and I'll get bullied. And so they might isolate themselves to try to protect themselves from that experience. And that also has really negative mental health outcomes. And so that's more of like how they're responding to the system around them. And then we see the same thing with anti-LGBTQ plus policies and legislation having really negative impacts on folks' mental health. After some of the more recent policies have passed in the last 2 to 3 years, we've seen significant increases in suicide risk, suicide ideation, suicide attempts among LGBTQ plus youth. When we see trans sports bans pass in states, we see increases in outreach to the Trevor Project Lifeline. And we've seen increases in outreach to the 988 LGBT specific helpline over time, as we've seen a proliferation of anti-LGBTQ plus policies. I think where this is particularly salient for youth and adolescents is thinking about the policies that occur in schools. So school boards pass different policies for how they're going to navigate LGBTQ identity. So things like book bans have negative impacts on LGBTQ adolescents' health. Even things like, are we going to let people have a safe bathroom to use, have really negative impacts. And so being aware of what the policies, including school policies in your community are related to LGBTQ plus identity is a really, really important step for being able to identify how your clients might be experiencing the milieu around them. We're about to transition into a little bit of some context around strengths and protective factors. And so I want to pause and see if there were any questions about risk factors, these health disparities that we're describing before we move forward.
Yeah, we have a couple questions.
Okay.
One's from Caroline. How do you manage seeing a client who identifies as trans? Sorry, just reloaded. How do you manage seeing a client who identifies as trans and is seeking gender affirming care but does not fit gender dysphoria, i.e., not experiencing distress or anxiety about their gender?
Yeah, it's a good question. And so I think that it's worth highlighting that there are a lot of different ways to be trans, and not everybody who is trans experiences dysphoria, but they still may want to make changes to their body. I tend to take the lens of people know themselves very well, and particularly for adults, it's not really my business what you want to do with your body, right? Like we do not have the same concerns about cisgender women who get cosmetic surgery or cisgender men who get cosmetic surgery. Those are also forms of gender affirming care. Like breast augmentation is gender affirming care for cisgender women. And yet we don't police that the same way that we police it for transgender individuals. Where it's tricky is then insurance companies won't reimburse or won't cover that care if there's not a gender dysphoria diagnosis. It may be worth exploring, like, if there are ways that gender dysphoria is presenting that doesn't look typical. So sometimes people aren't experiencing a great deal of distress because they know they're about to be able to change things, or because they've really come to terms with who they are and they believe that things will change over time. And so it might be worth exploring, like, whether is this because you know you're going to be able to access these things? If you weren't able to, what might that distress look like, to get a better sense of, is it that you aren't experiencing dysphoria? Or is it that you have hope, and so that mitigates the impact of the dysphoria, and we need to assess it more comprehensively? But in general, I tend to lean on people are who they say they are. I believe them. And particularly once you're over the age of 18, like you can make changes to your body, and it's not really my business what you do or don't do with your body, the same way I wouldn't police a cisgender person for making changes to their body. So I know that's maybe not a fully comprehensive answer, but I hope it gives you a starting place. And then there are some resources at the end that might be helpful for thinking about, like, there's a lot of work that can be done that really isn't about gender identity at all that could be useful. So those are at the end, and I'll make sure to point that out.
All right, thank you. And the last question for now is from Chantal. If therapists don't use a name for a person in session whilst working on family relationships, not gender affirming, for example, what is the current thinking about this?
I'm not 100% sure I understand the question, so let me just make sure I do. What I think I hear you saying is, like, family may not be affirming, and so you're trying not to use the youth or adolescent's chosen name in session with family to not out them while supporting, because you're not really talking about the gender identity stuff. I think that this is where some of those resources at the end. So one of the things I linked to is a place where you can get the transgender counseling competencies guide, which goes into some of those details, will be useful. But I do tend to err on the side of, if it's not safe for someone to be out to their family, I'm not going to out them to their family. And so you might have I lean into, how do I have an explicit conversation with the person that I'm working with about what their preferences are? So when I'm working with trans folks who may not want to be outed, I have really explicit conversations around, like, are there different ways I should refer to you when I'm talking to you one-on-one versus if we're talking with your family or if your parents call in? In my documentation, are there different pronouns you want me to use than the pronouns that I'm using for you while we're talking to one another? And we have really explicit conversations around that. And that includes explicit conversations around parental rights and what is legally required, as well as, like, how I can navigate confidentiality within that. So the short answer is, it's very complicated. And there's not necessarily a right way to do it, but I think involving the individual who might be at risk of family rejection or harm as much as possible and giving them informed consent. So here's what I have to do, and here's what we have choices about, and how do you want to navigate that together, is probably the most important thing that you can do. Y'all have
Uh,
such good questions.
All right, thank you.
Okay. So I know up to this point, it has been a little bit doom and gloom about outcomes. And despite these disparities we've described relative to cisgender straight people, most LGBTQ people, particularly LGBTQ adults, have positive health outcomes. In youth, we see that even these really negative health outcomes, they hover at around half to a little bit more than half. So it is still not the majority by a lot, right? It is barely over that majority line who are having these really negative health outcomes. And so there are pockets of vulnerability, and we need to be aware of those pockets to effectively meet people where they are and not blame them or pathologize their experience. But queer and trans people leverage strengths and resources and persist and thrive despite this adversity that we're describing. And I think it's important for us to know that when we overly emphasize these health inequities or health disparities, we're actually further perpetuating the stigma, because we're implying that all queer and trans people have poorer health or poorer mental health. And we're maybe not acknowledging the unique strengths and positive attributes that queer and trans people are bringing to their lives and to the work that they're doing. We ultimately might accidentally reinforce stereotypes about queer and trans people that we don't want to reinforce. I think a lot about, like, what is it like for LGBTQ plus youth specifically to hear these doom and gloom statistics? Like, how might that actually increase suicide ideation if it feels like there's no world in which they will have a happy life? And so I think it's really important that we acknowledge those pockets of vulnerability and risk, and acknowledge the real health disparities in that more queer and trans people experience worse health outcomes than the general population, without implying that that is a destiny that all queer and trans people will experience. It just feels really, really important. And so within that, there are some really unique strengths that emerge when we look at the literature, and just based on my own work working with queer and trans communities. So we see incredible resilience. And resilience is a loaded term, right? Because nobody chooses to be resilient. You kind of have to get through adversity. Like, I've had some students say, well, resilience is great and all, but it's like, it was be resilient or die, and I didn't want to die, right? So I like to reframe resilience as adaptive coping strategies that helped you survive, but also help you, like, get your needs met and help you move forward and help you have the life that you want to have, not just you survived this bad thing that happened to you. Community connectedness is also a strength, and this applies to other communities as well, but particularly for LGBTQ folks. We see that the more connected someone feels to community broadly, but also specifically LGBTQ identity, the better their mental health is, the better their physical health is, and the more that they feel like they are contributing to something. So there's a reciprocity tied to that. We also see that when we help people move toward identity pride, so we address internalized heterosexism or internalized cissexism, we see much better outcomes. So when people can be proud of who they are and not just not see it as a deficit, but see the strengths associated with being a queer person or a trans person, we see better health outcomes. People who are participating in community and actively engaged, so not just feeling connected, but showing up behaviorally, we also see that as a particular strength. And queer and trans people have these really creative and innovative social networks and supports. So we'll talk a little bit more about family of choice, but ways that, okay, if my family of origin rejected me, I will build a family structure somewhere else. I will still have that need met. And there's like deep community roots that can be embedded within that. We also see creativity and relationship quality. So when you step outside of rigidly prescribed gender roles and expectations within relationships, there's a lot of creative ways that you can have relationship. And so often queer and trans people can create relationships that better serve their individual needs because they're not having to follow a social script about what romantic relationships have to be. There's not really a good social script right now for LGBT relationships. And then we see resistance specifically as a form of adaptive coping. So political engagement and finding ways to resist the harmful social structures is really, really helpful. Building out from those strengths, we see these things as protective factors. And most of these things, not all of them, but most of these things are changeable and therefore things that we can target in counseling to better support the people that we're working with. So again, social support. That can look both just like broadly, do I have people who care about me and who I care about and we help each other, as well as LGBT plus specific social support. So when we see people be more connected to LGBT specific resources, we tend to see better outcomes. That community connectedness and creative coping strategies emerge as coping or as protective factors. And then there are some systemic or contextual factors that we see as protective. So people who have better healthcare access tend to, shockingly, have better health outcomes. So we know that when folks are able to access services, they do benefit from them and we see better outcomes. Also, folks who have more financial resources tend to be better protected, in part because things like employment discrimination, while emotionally hurtful, don't also then have social consequences for one's life. Like you're not going to not be able to pay your rent and become housing unstable if you have financial resources to support you through an employment discrimination experience. People who are more highly educated tend to have better health outcomes in this community that might tie with the financial resources and having access to certain kinds of employment. And we also see that generally queer and trans people who live in urban areas like cities have better mental health outcomes than rural areas where there may be fewer supports available to them. So this is not to say that people who don't have these things are not capable of having better health outcomes, but it's instead to highlight that these are, like that top row, are all things that you as clinicians can address. You can help people develop different kinds of social support, get connected with LGBT community and their community more broadly, and develop coping. Whereas others might be more contextual, but there are ways that we can navigate that. When we look at LGBTQ youth or adolescents specifically, the number one protective factor is being in a family that affirms and accepts you as an LGBT person. The research is pretty consistent that that seems to have the strongest relationship with positive health outcomes. And so frequently when we're working with youth and adolescents, we have to be working with their families to some degree as well. I think that's true regardless of LGBT identity. Like, I just don't know how you work with someone 18 and younger without involving their family. But particularly for LGBTQ youth, helping family get on the same page about affirming and accepting is the most helpful thing we can do for the individual client that we're working with. We also see that having positive peer relationships is a protective factor. And again, when they are able to have positive relationships with LGBT peers, that relationship is even stronger. But when they're not, when it's just regular, like other peers who aren't LGBTQ, that is still a protective factor. Also, having role models, particularly adult role models who are LGBTQ, is really, really helpful. And that's part of where we see some of those policies like don't say gay in some of the schools being harmful to kids because they need to see that there are healthy, happy adults who are like them. Because so much of the narrative is that being LGBTQ is a sad, bad thing and bad things will happen to you. We also see, you can see some of the connections with what we see for adults as well. So the community connectedness, LGBTQ plus community access. So will your parents take you to the local LGBTQ community center? Or I know here in Tennessee, and when I lived in Oklahoma, they were there as well. There are sometimes these youth camps that are focused on supporting LGBT youth specifically. There's also online communities. So particularly for youth in rural communities or states that are more disaffirming, being able to connect online with other LGBTQ youth is a really, really helpful protective strategy. And there are some inherent risks in that, right? Like there's no guarantee that who you're talking to is who they say they are. And so sometimes we do need to have some like safeguards around making sure that folks are well supported and engaging in online community. Gender sexuality alliances in schools. This used to be called gay straight alliances in school. We've kind of shifted it to be more inclusive of transgender people. These have really excellent outcomes. So youth who are in schools with GSAs tend to have better outcomes than youth who are in schools that don't have them. It's an institutional support. So it ties in with this like legal and school policy protections where you have explicit affirmation and acceptance, you just tend to have better outcomes. And then when we can engage in intersecting forms of recognition, so really seeing people holistically, that goes back to that double rainbow thing we talked about before. So seeing, for example, an autistic non-binary youth holistically for who they are is one of the most powerful things that we can do for them. So a lot of this has to do with how the system around an individual youth or adolescent is responding to them. But then there are still things within that we can do to support them. We're about to transition into talking explicitly about LGBTQ plus affirming care, so strategies and things you can do. But I want to pause and see if there were questions about these protective factors or strengths before we finish that transition.
I'm not seeing any questions right now.
Okay, great. Then we'll keep going, and we're going to talk about some strategies that I hope you'll be able to use in your work to better support LGBTQ plus clients in general. So first, what is LGBTQ affirming care? I think that's a term we hear thrown around a lot. And it's a wide range of social, psychological, behavioral, and medical interventions that are designed to support and affirm an individual's sexual and or gender identity. And frequently those medical interventions are more for transgender and non-binary individuals than people with diverse sexual orientation identities, because frequently you don't need a medical change to your body to affirm that part of your experience. But things like hormone replacement therapy, puberty blockers, some surgical interventions can be really helpful in ensuring that people's gender expression aligns with their gender identity and how they want to present themselves to the world. So that's also where, again, tying in a little bit with that letter writing piece, we'll get into that here as we think about affirming care, because this is where we do some of that work. We also, the LGBTQ affirming care is a set of attitudes or approaches rather than specific techniques. So you're not going to leave here being like, oh, this is a manualized approach and I'm going to do X, Y, and Z, and then I'll have done affirming care. It is much more about like how we are with people than did I do this discrete technique or intervention. The aim is to create a welcoming environment where people feel actively recognized and supported. So we're going beyond just I accept you for who you are to I celebrate who you are. You like being queer or trans is not a neutral thing, but a positive thing. And I'm excited that you're here and I'm excited that you trusted me with who you are. That's really what we're trying to do with LGBTQ affirming care. And so we've got some core principles here that I hope help you understand how to infuse this into your work. So first, it has to do, if there is a specific technique, I do think attending to your language is one of them, which is why we spent so much time on language at the start. And so it's really important to use inclusive language. So reducing heteronormative and cisnormative bias, reducing the ways that we might imply that being straight is the norm, or that being cisgender is the standard, and instead kind of owning that everybody could have diverse experiences and anyone we're sitting across from could be an LGBTQ plus person. One of the ways that I like to do this is the use of pronouns. So I introduce myself with my own pronouns, even though I think many people could correctly assume my pronouns looking at me. There are other people who might look like me and not use she, her pronouns. And so I model, my name is Jordan, I use she, her pronouns, and I try to use affirmative gender neutral language. So if I'm asking people about their romantic relationships in an intake, I don't assume what kind of partners they might have had based on their gender expression. I might ask them to tell me a little bit about romantic relationships they've had, rather than asking, do you have a girlfriend or do you have a boyfriend? Little tweaks like that make such a difference in demonstrating that you're a safe place to talk about LGBTQ plus identity. It's also an explicitly affirmative stance. Like I said before, we're going beyond acceptance to affirmation. And this is a place where people get stuck sometimes because they're like, well, I'm not supposed to impose my values. So what if a client is coming in and they don't like that they're queer? And I'm saying, no, it's a great thing that you're queer. So your stance does not have to be the feelings of the client. Meaning that, like, if a client comes in and they're like, I want to see you because I want you to help me change my gender identity, I'm going to explain that I am not able to do that ethically. There's no research that it works and it actually causes harm. And that, like, my worldview is that not only is there nothing wrong with being transgender, but I actually think that it's a really beautiful thing when people know themselves well enough to know who they are and are brave enough to live that out. And you don't have to feel that way about yourself, but that's how I feel generally about that identity. And so we can work together on kind of helping you make sense of who you are and how you feel about this. So that's kind of how you can separate out, like, I'm not going to impose my values, but I am going to own this affirmative stance, in part as a way to help deconstruct internalized stigma. Cultural humility is also central to LGBTQ plus affirming care, which is really just an understanding of the limitations in one's own experience. All of us are cultural beings. And so we are all coming from our unique cultural context, and that's going to influence the way we see the world. And so being able to catch those moments and recognize, like, oh, that's coming from my worldview. And so I need to bracket that and step into their worldview, or like, oh, I didn't know that. I need to go do some research on this so that this person's not having to teach me the basics of their culture and can instead teach me what it's like to be them in their culture. It's a commitment to lifelong learning and critical reflection. So we recognize that cultural humility and cultural competence is an evolving process, and it is never something we have arrived at or achieved, but is instead something we are perpetually working toward. It's aspirational rather than achieved. And then maintaining an openness to feedback. So by modeling cultural humility, by taking a culturally humble stance in clinical work, we invite our clients to tell us when we've done something wrong or said the wrong thing, and demonstrated that we're open to repair and able to navigate that relationally with them, which is really, really important. And finally, it's a holistic, person-centered approach. So it is our responsibility as clinicians to come to trainings like this one. So you did the first step. And to educate ourselves on the community as a whole. Your client shouldn't be teaching you, well, this is what lesbian means, but they can teach you, this is what it means to me to be a lesbian, right? So the idea is that we build the understanding about broad cultural language or some of the statistics, and then you can help me understand what it's like to be you, rather than like teach me your whole culture. And that lets us individualize our understanding rather than saying, well, all LGBT people must be at risk of suicide. So I'm going to ask you that question every week, even though you told me that you've never had a suicide thought. It also understands the unique identities of the individual. So it looks at the intersections of someone's identity. And so there are different experiences for different people who are queer and trans, right? Like a white trans person might be having a very different experience than a Black trans person based on how society is responding to them. So that intersection of racism and cissexism, as well as maybe cultural values, ways that they're navigating family contexts. And so we want to understand them holistically through that lens. So who they are all together, but also who they are outside of social and cultural identities, right? Those things are kind of talking to each other. And when we overemphasize one or the other, we might make some missteps. We're about to move into more specific techniques. So I'll pause now that we've done the broad overview and make sure that I'm not missing any questions about affirming care generally.
Yeah, we have one from Gina. With the current administration, there have been a lot of my clients that are rightly so scared of what the future may hold.
Yeah.
How do you provide coping for them when half of them want to leave the country and the other half don't have the means to?
Yeah, it's a really, really tough question. And I think one of the most important things that we can do is not invalidate that fear. And I hear you naming on the front end that it is real. So validating, like, this is a real thing. And it can be very helpful to look at. So there are things outside of your control. There are things that we can't do anything about. So how do we identify what is in your control and what will work? I often work with my students more than clients at this point. I'm not currently in direct clinical practice, but around talking about like, okay, so how do we empower people to use the choices that they do have and to lean into mutual aid and build those robust community connections? A mantra that's been helpful for folks is kind of understanding that autocracy cannot thrive when we are connected and experiencing joy. Like it thrives on fear, and your fear makes sense. And how do we also find pockets of joy for you, if only as a form of resistance, if only as a like, you don't get to take this from me too. I also have worked pretty explicitly with some of my students, and honestly, as a queer woman in Tennessee who's married to a non-binary person in Tennessee, like talking through safety planning and what would be the points at which it was untenable to stay and we would have to take on additional debt. What are the things that we can do to create safety within this context that is pretty unsafe for LGBTQ people generally? So I think it's a balance of acknowledging the reality, doing some harm reduction within that reality, and then finding the components that are still within our control and how we can almost like refuse to let the fear steal our joy. I also have been personally revisiting some of the activism that happened around the AIDS epidemic and the HIV crisis, because I think that there were some similar constructs around that time related to governmental support and how people were being targeted and how people were dying, and leaning into like, how did communities survive that? How did communities like create this robust queer community that we have today, even as they were being decimated by this disease? And that's given me hope, even in grief. And so that's a tool that I share with my students and that I've had them share with their clients that's been helpful. But there's not like a right answer right now. It's strange and unprecedented and scary. And I think we have to like live in that reality with our clients the same way we would as like they're facing other things that are outside of their control. But are negatively impacting their mental health.
All right, thank you. We have one from Melinda. I would like to better understand the meaning when someone's pronouns are different. For example, she, her versus she, they. My assumption is that is more non-binary. If so, wondering if there is meaning in using she, they versus they, them.
Great question. So for a lot of people, the pronouns that feel most right to them might evolve. It might be that they do identify as non-binary or more gender fluid. And that's a place where stepping into that conversation with the individual and asking them what it means to them and how they want you to use those pronouns can be most helpful. So frequently when I see like she, they, I'll have an explicit conversation with that individual about like, I notice you use both she, her, and they, them pronouns. And I'm wondering, when you're talking with people, how do you like that to happen? Do you like people to intermix them to honor your gender? Is it more that you're comfortable with both and don't care which people use? And kind of exploring with them, like, what does it actually mean for them to use this different relationship of pronouns? And similarly, there are some folks who say, you can use any pronouns for me, I don't care. And then I like to lean into like, okay, so if that's the case, is there a preference? Like, do you like for people to intermix pronouns so that you feel really seen? Do you like people to pick one pronoun and stick with it so that you know they're talking about you specifically? So it really is a very individual process. It frequently is associated with the umbrella term non-binary rather than non-binary as an explicit identity of folks who maybe don't identify as men or women, but one of the other identities under that umbrella. So I hope that gives you like some starting tips for understanding, but also like what to do to better support people who might use those pronouns and kind of know how to speak to them and about them.
All right, thank you. We have another question from Anna. How do you suggest handling disclosure of your own sexual orientation in sessions? I typically don't, but as a heterosexual person that works with a lot of queer clients, I'm often wondering if I should disclose that.
Ooh, such a good question. And I think it's a really personal answer. So you'll have to navigate that for yourself. I'll say that when I was in direct practice as a queer person, I initially didn't disclose because I was in rural Oklahoma and I was a little bit nervous about safety. And then I got to a place where I decided I would disclose most of the time because I thought it was helpful for people to know, particularly queer and trans clients that I was working with. And so I think that it's really a personal negotiation. I think that when people explicitly ask you, you might have to make a decision about Do I want to share that I identify as straight or heterosexual, or do I want to kind of set a boundary and not disclose here? And be okay with, if someone is asking you and you choose not to disclose, they might not continue to see you because they might want the safety of knowing that they can talk about similarities and differences. So there's not really a right or wrong way to do it. I think it's personal preference. I think it's about, what's the purpose of the disclosure? Does it support the client in some way? And then it's also about like your own comfort and safety in disclosure. And even as a straight person, right? Like sometimes by broaching that, there might be a conversation about sexual orientation that you have to step into with somebody who maybe holds more prejudiced beliefs about LGBTQ identity that then you would have to figure out how to navigate.
All right, thank you. One more from Anna. Do you have any recommendations for how to ask about someone's process of coming out slash figuring out their sexual slash gender identity in assignment?
Yeah, so I think that that's such a good question. And one piece that's important to hold is that we sometimes overemphasize the coming out process with our LGBT clients. And it doesn't mean you don't ask about it, but I think I've seen sometimes people think that that is the defining story about LGBTQ people's identities. And that's simply not the case. Like many times people are coming in, they're like, my coming out was fine, I don't want to talk about it. And then you just let it go. But I think it can be really helpful. We're going to get into some cultural broaching techniques a little bit later on. And so it can be really helpful to use some of those strategies. So I'm just jotting down a note to myself to explicitly talk about the specific questions we can use in broaching that get to that developmental process, as well as learning more about somebody's coming out story.
All right, and the last question for now from Gina. I also know a lot of my clients that are starting to hide their identity, i.e., changing their clothing, taking pride flags down, growing hair out, stopping hormones, etc. The fear is valid and people are being extremely hateful. The increase of anxiety, depression, and self-injury is concerning, and it's difficult as a clinician to give hope when there's so much uncertainty. How do you
Mhm.
encourage a client to be themselves when themselves could bring a target to them?
Yeah. This is going to sound strange, but I don't. And not as in like, I don't say like find places and ways to be yourself, but we end up having a harm reduction conversation. And I have to trust my client's autonomy that they know which kind of harm is worse for them. So the harm of being targeted as a trans person or a queer person, or the harm of having to closet again. And so what I would probably do in that situation is have pretty explicit conversations about the risks and benefits of staying out and living more authentically and having to navigate hypervigilance in moving through your environment versus closeting again, and the experiences of dysphoria and distress that might come from identity concealment. And how are we going to get some safety plans and coping in place to support you in either instance, because neither is a good option right now. And then when I'm doing that work, I do also focus in on what are the places where you can be you. So you are having, if what you land on as the safest choice for you, taking into account all the factors we've talked about, is to closet again, where are the places that it is safe to be you? Where are the friends who will call you by the right name and pronouns? Where are the places where you could wear makeup or not wear makeup and know that you would be safe? So that there are like identifying the pockets where there you can still be yourself, even if you still have to, like the term I've heard some of the trans folks that I work with use is like go boy mode or girl mode to stay safe. Um, let's find the places where you don't have to do that, if that's the decision you end up making, to give you a reprieve from the constant stressor that you would be under navigating that. It's a really good question. And there's not necessarily a good black and white answer, particularly in this context, which is hard.
All right,
Thank
thank
y'all.
you.
Yeah, thank y'all for these questions. They're great. I also know we have like 35 minutes left and so much to talk about. So I'm going to move us forward. May not take quite as many questions during, but we'll save some time for questions after. And I have time to stay out a little bit longer if that's helpful. Um, so when I think about like how you can demonstrate that welcoming, affirming environment from the start, this is like before you've even talked to the individual you're working with, in a way that basically would allow people to find your services and know you're a safe place. So inclusive advertising, explicitly saying that you provide LGBTQ affirming care. So not just saying you work with LGBTQ plus topics, because there are sometimes religious providers who say that and then will engage in like sexual orientation or gender identity change efforts, but instead explicitly advertising an affirmative approach. You also want to include explicit affirmation on websites and any publicly facing materials that might look like including a little rainbow or a picture of a pride flag. It might look like a statement that explicitly speaks to how you affirm LGBTQ identity. It might be like, there's all kinds of different ways that you can make it explicit rather than implicit that you're affirming. Now, I will also recognize that for some of the queer and trans therapists on this call, right, like we are also providers of counseling, that might not feel as safe for us, because we don't want to be targets given that we're at risk of the same social and cultural milieu. And so you might have to navigate your own way of doing that differently. Some people may choose not to be as explicit and rely on implicit word of mouth referrals to make sure that they stay safe in the process. And so I recognize that not all of us have access to do this the same way. In your intake forms, there are also ways that you can be more inclusive in the specific paperwork. So you can use an open gender question. So like, please describe your gender, and they don't have to check box, but they can write it. If you have to collect sex assigned at birth, explicitly call it that and only collect it if you need it, like for insurance purposes, and make that clear as to why. You also might include an option to report sexual orientation. One of my favorite additions that I've seen on intake forms is the option to write in your pronouns. So like something like, what pronouns should I use for you? And people can choose to leave this stuff blank if they don't want to answer it. But it kind of is modeling from the very beginning, before someone's even sat across from you, that you will affirm them and you have some awareness of these topics, which creates safety. You can also engage some strategies from the beginning to establish affirming relationships. So like I said before, introducing yourself with your pronouns, and then inviting but not requiring disclosure of your client's pronouns. So what my shtick now, it used to be like, oh yeah, tell me your pronouns. And then I realized there are some people who aren't safe yet to be out, but wouldn't want to have to like not tell you. And so now I make it a choice. It's kind of like, so hi, my name is Jordan. I use she, her pronouns. It's really great to meet you. You know, I saw this was your name on your paperwork. What name should I use for you? And like, if you're comfortable sharing what pronouns, you don't have to. And then they can kind of decide what to disclose or what not to disclose. Similarly, I would encourage you to recognize that any person sitting across from you could be an LGBTQ person. So don't assume heterosexual or cisgender identity, even when there are indicators that might say it. So like if someone comes in, like a woman, and wearing a wedding ring references a husband, that person could still be bisexual, or that person could be transgender and you might not know. And so not making assumptions, but being open and curious about people's experiences. And I already talked about this a little bit before, but I wanted to explicitly call out how we navigate when people explicitly come in asking for conversion therapy, so sexual orientation or gender identity change therapy. I say from the beginning, I do not do this. I will not pretend that I will help you do that and then not do it. I will explicitly say, no, I don't do conversion therapy, but I include why. I think it's really important to explain why, so that it doesn't just feel like you are imposing your values, but explaining the research base. None of the research suggests that it is effective. In fact, most of the research suggests that sexual orientation and gender identity are innate and unchangeable, and these change efforts may help somebody live in the closet longer, but typically doesn't actually make change to who somebody is. And then there's a lot of research that supports that it is actively harmful. And so my ethical code says that I have to do the most good and do the least harm. And so I can't engage a therapy that does no good and is very likely to induce harm. And then from that, I'll explore reactions like, what's that like to hear from me, and reflect back the disappointment and frustration and engage with it like I would any other counseling topic. Because I think that can be really powerful in showing, just because I'm not willing to do this, it does not mean I'm going to force you to step into my worldview. And it doesn't mean that I'm going to reject you. Like, you don't have to be excited about this, even though I take a stance that LGBT identity is something to be celebrated, and we can work together on that. And now we can get into some of the more specific culturally sustaining techniques. And I'm going to pull in the letter writing component and the coming out questions from those questions earlier in our conversation. One of the most powerful interventions in counseling broadly, in my opinion, is broaching. This is an ongoing process that draws explicit attention to cultural factors, including LGBTQ identity, and how they impact the therapeutic relationship that you have with someone. So in terms of broaching, that can look like maybe early on inviting people to share a little bit about who they are. So to the question earlier about asking about coming out and the development of sexual orientation, you might start broaching by just asking, we're all cultural beings. We all carry our lived experiences, including our social and cultural experiences, into the room. What are some things that are important for me to know about you to really understand you as a person, and inviting them to share? If you are explicitly discussing sexual orientation, like collecting that as demographic information, asking directly, so how would you currently identify your sexual orientation? And then if they disclose a non-heterosexual or a queer sexual orientation, you might be able to ask things like, when did you first notice that? How long have you known? What has it been like to navigate the world as a queer person? You might ask about, when did you come out? What was that experience like for you? What lingering thoughts or concerns do you have about it? So it's just pretty clear, open questions about what those experiences were like. And if someone's like, yeah, my coming out was fine, it wasn't that important, we don't have to stay on it. We don't have to press, we can move forward. And in the last section of our PowerPoint, we're going to talk a little bit about unique developmental experiences and developmental milestones for LGBTQ folks. And so those are specific things you can ask about as well. So I'll point those out when we get there. Later on in the relationship, because again, it's an ongoing relationship, you can also explore, like, what's it been like for us to talk about your sexual orientation, or what's it been like for us to talk about your gender identity? When there's cross-cultural differences, what's it been like for you as a trans person or a non-binary person to work with me as a cisgender person? What's it been like to work with me as a straight person? And so explicitly drawing attention to cultural similarities and differences in the relationship and how those things have impacted process over time can be really powerful, and communicate and model to the client that it's appropriate to talk about these topics and that we're excited to talk about those topics with them. We also want to attend to family systems, including family of choice. I think I've spoken about that quite a bit over the course of this presentation, so I won't expand on it much here, but just want to keep reminding you to really pay attention to how the family of origin operates, but also who the individual considers to be their family now and how that family system operates. I also think it's really important to engage empowerment strategies. So this gets at some of the questions we've been having today around, like, our current sociopolitical context is quite hostile to LGBTQ people. More than 800 anti-LGBT bills have been introduced across the United States in the last 5 years, and nearly 100 of them have been signed into law in the past 3 years. There's never been a legal push like this for this community specifically in the same way. And like, we kind of had this progression of civil rights and now we're suddenly backsliding. And so being aware of how that's impacting clients that you're working with, and then figuring out, how can I advocate on behalf of this population at the socio-political level, but also how do I empower clients to take back agency and engage where it feels safe for them, to get some agency back over the ways that these things are impacting their lives is really, really important. And then there's a lot of research that suggests that relationally focused approaches are particularly effective with LGBTQ individuals. So just recognizing that that's part of why I think processing the relationship and attending to their social supports are so important. And when you look at the protective factors, it makes sense that something that's about relationship would then help them with those components of community connectedness, social support, meaningful peer relationships, role modeling relationships, those things that are very protective for mental health. And so I'm going to pull back in the question about the letter earlier, which is about how we recognize that there are a lot of people who want to access gender affirming care, particularly because there's a chance it's going to be taken away. And so people want access while they have access. But the WPATH standards and guidelines, and for folks who aren't familiar, WPATH offers clinical guidelines for how to work with transgender individuals, as well as how to provide support for medical, like gender affirming medical care specifically. And often a part of those requirements is engaging in counseling services over a 6-month period of time. But so you probably have some folks coming in and saying, I really need a letter because I need to get access to this. And so there are some different ways to navigate it. You can't lie, unfortunately. You can't lie and say, yes, I've been seeing this person for 6 months. That's malpractice. It opens you up to legal liability. Some people might choose to do so anyway as a form of advocacy, and that's your decision. But legally, it isn't really an appropriate thing to do. And ethically, I think it's more of a gray area. It might be in an ethical decision-making dilemma. So other ways that you can kind of navigate that is have conversations around, like, what would it look like to have to pay out of pocket for this for a little bit? Or how can I get you connected with Planned Parenthood, which might be able to get around your insurance not covering it? Or like, what are other options that we have in the meantime? And then how can we make it the least cost prohibitive process as possible for them to access the care that they need to get the letter that they need? So is it possible to meet once a month instead of every week over a 6-month period? Because it's about the duration of the relationship, not the number of sessions. Is it possible to give somebody a sliding scale spot or pro bono services because access financially is a bit of a barrier. So just thinking about how we can get creative in increasing access while adhering to the standards of care. Some people also would say like, okay, well, I'm going to write a letter that's not in alignment with the WPATH guidelines. Like I'm going to write a letter and I'm going to acknowledge like I have not been seeing them for this duration of time that WPATH says is important. But I still believe that this is an appropriate intervention. And so there's a lot of different ways that you can navigate it. And I will see if I can find some specific resources and share them after the fact for some of the nuances there, because I think it is a really important question. Some final tips for these like culturally sustaining strategies and cultural like LGBT affirming care is, again, we're trying to maintain our own affirmative stance without saying that our client has to buy into our worldview. I would love it if every queer and trans person celebrated their identity and had pride. And it's also not my place to say that that has to be the direction that they go. It's really helpful to support your work with an evidence base. So being able to go back to the literature and say, this is why conversion therapy doesn't work, or this is why we're focusing on this topic can be very, very helpful. In terms of knowing how to better support people and engage those protective factors we talked about before, one of the most important things, I think people tend to think LGBT identity has to be separate from a faith identity, and that's not true. They can actually be quite interconnected. So learning about affirming faith-based organizations in your area feels really, really important, and figuring out like, where could I refer somebody? I think about when I was in direct clinical practice, I was working with a young Black woman who belonged to a Black Baptist church and was sexually attracted to other women and was really, really struggling with the messages she received at church. And so I found specifically Black churches that had an affirming stance, because I needed to step into her cultural context, but offer like, you know, I'm a white woman coming in saying, I don't think God hates you for being gay, and I'm not from your same religious context. So how do I give you a religious like support context that you can go to and decide if that's a better fit for you? Similarly, looking for LGBTQ plus specific organizations and resources. So I mentioned it before, but PFLAG, wherever you are, they have chapters nationally. They have virtual meetings. PFLAG is so helpful for families, including families who are like trying to learn how to be supportive, but still have some bias to unlearn. PFLAG is a great resource for those families. It's also really important that you stay up to date on the legal context in your area. We've made many allusions to that throughout this presentation. And then just a final note is that sometimes when I see people wanting to do this work well, they accidentally swing to the other side. And so they overemphasize LGBT identity. And it's kind of this constant like, oh, well, and that must connect to this as a queer person. And it's like, no, I just want to talk about my mom. Like my queer identity actually isn't that salient. And so recognizing that we don't want to be like culture blind and ignore LGBT identity, but we also kind of want to take our clients' lead and recognize if they're saying like, no, I'm good with that, that's not really why I'm here. We can listen for where it's connected and reflect that back. But if we overemphasize it, it comes across as tokenizing, and that can be harmful and a microaggression in and of itself. All right, so we're about to transition briefly into talking about support in context, and then we'll wrap up our time. So I'll quickly take like 1 or 2 questions from that skills section and then run through this and save a little bit more time for questions at the end. If there are any other questions, there might not be.
Yeah, there's no questions on that right now.
Okay, great. Then we will move through support and context, and I'll make sure we take some more questions at the end. So I think it's helpful to revisit our Braun from Brenner, that ecological systems approach, right? And recognize that queer and trans people, like all people, are impacted by the systems and contexts in which they develop. And it's really important to consider those unique developmental considerations and milestones, as well as recognize that systems might look different based on LGBTQ plus identity. So the way that someone's microsystem and mesosystem is constructed might be impacted by family of choice. And so I'm attending to all the different ways that these things are intersecting in a person's life, and these ecological considerations are particularly important when we're working with marginalized people in general and LGBTQ people specifically. The chronosystem especially is important. And you've heard some of that throughout this presentation with questions focused on our current political context and the stories that are being told about LGBTQ plus individuals. So the ways that we're currently in a time of political backlash, that is shaping how people understand themselves as an LGBTQ plus person. So, and our generations tend to be very short. So I would say because of the rapid change in civil rights, like every 5 years, an LGBTQ person coming of age is having a very different experience than someone 5 years before them, because we've just had such a rapid change in the civil rights context. And so one of the ways that you might want to explore that is understanding what was the social system like for you when you were coming to an awareness of your LGBT identity? What was it like for you as you were coming out? And what is it like for you right now? Because those are going to be very different things. To that end, we kind of have three major cohorts of LGBTQ plus adults. So the oldest cohort are 55 and older, the Pride cohort, and they would have come of age during or before LGBTQ plus civil rights. So during the Stonewall riots, during the HIV/AIDS epidemics, would have maybe even been, there might be some people who also experienced like McCarthyism and the Lavender Scare. And so there's a lot of historical context that really shapes the way that they engage with the world. But also those are the elders who really set the stage for our current civil rights and what our community looks like. In the middle, we have that middle-aged cohort in our 30s and 40s, the visibility cohort. So this is a group that would have come of age after that initial civil rights movement. So after Stonewall and the subsequent like decade and a half. But prior to these positive legislation changes in the 2010s. So this is actually the cohort I would belong to, right? So I grew up in the 90s and early aughts, and gay was an insult. And I was an adult when same gender marriage was made legal, and I had only come out a few months before. And so it was kind of a sandwich cohort of we're visible, but like, I don't know if there's actually a space for me, and I don't know what it would look like to live a life as an LGBT person with all these protections. And then our youngest cohort is the inclusion cohort, who would have come of age during a period of advancement of civil rights. So like 2012 to probably 2020, we start to see things backslide a little like around 2017, but the dramatic increase was like 2021. And so now we have a current cohort who's coming of age during a serious period of backlash. And I'm not sure what those developmental experiences are going to look like for them. We're kind of going to be learning that as we go. So when we think about lifespan development, right, it's very, very salient. I don't like identity development models that are stage models for LGBTQ persons. I think that it implies that there is a sequential way that you come to an awareness of self, and that just doesn't seem to be the case according to the research, my own experience, or the experience I see in my students and clients. And so I really like this life course process model, which might be helpful for you in thinking about what are important developmental tasks for queer and trans people, both in adolescence and adulthood. And this is this idea that our identity is shaped through interactions with the environment across the life course. So it brings in that chronosystem lens from Bronfenbrenner and helps us understand how the social context that we're in influences the way we come to understand ourselves as a queer or a trans person. And so some of the processes that I can't pronounce their last name, I'm sorry, Jelly proposed includes like exiting a heterosexual or cisgender identity. So we like are kind of told that's who we have to be, and then we have to exit that. Developing a personal LGBTQ identity status. So what is the label that I give to my LGBTQ identity, and what does that mean to me? Developing an LGBTQ plus social identity. So how do I engage with the world now as a social being? Like, what do my friendships look like? What do my romantic relationships look like? Which kind of gets into another stage. How do I show up in community? We have becoming an LGBTQ plus offspring, which I really appreciate. Like there's some shifts, right? So for trans people, it might be, you thought I was your daughter, but I'm actually your son. Or you thought I was your daughter, but I'm your child. I'm not a woman or a man. And so there's kind of a shift in what does our relationship look like now that you can know me more holistically. Or for a queer person, it might be, you had this vision for my life that I was going to marry someone of this gender and I was going to have this kind of a nuclear family. And that's not what I'm going to do. And so how do we renegotiate our relationship to each other when these expectations you had of me are not going to happen? Or may happen, but happen very differently than what you thought was going to happen for me. We also have developing an LGBTQ plus intimacy status. So how do I want to do romantic relationships? How do I want to do sexual relationships? How does that fit the social scripts I've been given for these kinds of relationships, and how does it not? And kind of an invitation to figure out, who am I in this context, and what is that going to look like? There are also some unique developmental milestones that are important to be aware of. The age at which these things happen and the social context around an individual when these things happened are really important for holistically understanding them. So there's an age of awareness of LGBTQ plus identity. So kind of, when did you know that you experienced attraction to somebody of the same gender? Or when did you know that the gender that we told you you were didn't quite fit, even if you didn't know what did fit instead? So that awareness of frequently how this expresses is not like, I knew I was gay, but it's, I knew there was something different about me. I didn't have language for it yet, but I knew something was different. And this is where it's so important that children do have access to stories about LGBTQ plus people, because that gives folks the language for, it's not just that I feel different and weird and other, so I'm going to isolate myself, but it's like, oh no, there are other people like me, and this is the name for that thing I'm experiencing. So that's a really important milestone. And people might have multiple ages of awareness. So it might be like, I realized I was different, and then I realized I had a crush, and then I realized I wanted this kind of relationship. Or it might be like, I realized that I was different because of my sexual orientation. And then in that, I like came to realize that my gender wasn't what I thought it was. So this can happen multiple ways. We also have age of disclosure. So the age at which an individual shared for the first time. So that coming out process. And there might be multiple coming outs, multiple disclosures, and what those look like. And then some of those other developmental pieces are the degree to which somebody is out and stays out. So are you out in every context of your life? Are you only out it with your friends, but not your family? Or are you out at work and with friends and with family, but not at church? There might be a lot of different ways that people navigate their outness. And then the degree to which people are involved in the LGBTQ plus community broadly, as well as LGBTQ political action and activism. Those become developmental milestones, even if people kind of come into community and decide, I'm gay, but I don't really want to be a part of this part of the community. Like, they can make that choice, but there's usually some degree of engagement at some point that becomes a part of the developmental story of a person's life. One last thing as I get close to closing out, I know we only have about 10 minutes left. And again, I'm happy to stick around for some extra questions. But I'm thinking about, how do we support LGBTQ youth who are in disaffirming families? This is a question I get a lot when I'm thinking about how we do this work. And so it's important to be clear with the family, not just when an individual is coming and saying, I want you to change me, but to tell the family, I will not engage in conversion therapy efforts. I will not try to change your child's sexual orientation or gender identity. It's unethical and ineffective. That same messaging. Explaining to the family why you take an LGBTQ plus affirming stance can sometimes help them understand. So naming some of the risks of what happens when LGBTQ youth are not supported, and not in a like, it's going to be your fault if this thing happens way, but in a like, to me, it's really important that we take this stance, because I know that when LGBTQ youth are not affirmed, we see greater rates of depression, anxiety, self-harm, and even suicide risk. And so to me, it is really important that we celebrate who this person is and help them figure out who they are and stay here. It can also be really helpful to highlight like why having family support is so important. So it's like, look, you don't have to be totally on board here yet, but being able to be supportive and kind and accepting of your child is going to give them way better mental health outcomes in the long run. Like, that is really important. And you can use relevant literature to support all of this. So it's not just your opinion, but you're pointing to research and helping them understand that there's a lot of evidence to back this up. I also will say, when you're working with a disaffirming family, family members are allowed to have their reactions. I wish that they would not have them with the youth, right? I don't think that it's appropriate for them to be grieving. Like, I see sometimes people being like, well, my daughter is dead and now I have to get to know my son. And that's really unhelpful. That can be harmful to the youth. But they also are allowed to feel that way. It's about finding appropriate avenues for processing that. So getting into personal counseling, connecting with PFLAG, finding those places where you can have your feelings, but you're not expecting the youth to hear about that, and you're not making their experience about you. That's really, really important. So sometimes if I can tell a family is struggling, I would recommend let's have a parent session, like you and me, let's just sit down and talk. And, your kid doesn't really need to be here for this one, and kind of helping them connect with the resources that will move through that process. On the other hand, there can still be legitimate challenges in supporting LGBTQ youth, even when they are in affirming family contexts. In part because just because somebody's family is affirming does not mean that the community that they're in is affirming. I think about folks who are in rural communities, and they might have exceptional parents who celebrate them and love them, but at school they're facing bullying from teachers and peers. Or, there were folks on this call talking about, like, people are thinking about, how do I get my kid out of this state, because the state is such a hostile place for them to be. And so this is a really important way to empower the family and the individual, particularly the family, in how can you make safety plans? How can you own where your agency exists in this? And how can we engage in advocacy while also knowing harm reduction and how we get you out? So supporting families and knowing what their legal rights are, engaging in safety planning and helping them think through an escape strategy if and when they might need that. I know that there was a talk in Texas about potentially removing LGBT kids, particularly transgender kids, from affirming families because that was considered a form of child abuse. And so there's some real risks where families, even if they can't afford to, might have to take on tremendous financial burden to keep their children safe. And so if we engage those conversations early and often in a way that is not alarming, but a way that acknowledges like, hey, this is our reality. What do you want to do with it? I think that that is really supportive and really, really helps these families and youth. I also think family therapy can be really helpful, even in affirming families, because it can help kids learn how to talk to their parents about this stuff. It can help parents know how to better support their kids. When parents are on board, it's fantastic. Or guardians, it's not always parents. It's so exciting. It's really fantastic. And sometimes being on board doesn't mean they know how to be supportive. So family therapy can be a really helpful place to help people learn how to communicate with each other and help parents or guardians know how to be a better support. And finally, there's often contexts where some members of a family might be affirming while others are disaffirming. So like thinking about if you're working, for example, with a child in a divorced family, and let's say dad is really affirming and mom is not affirming. Then you might be navigating some tension there between how they choose to parent, messages that the kiddo is getting in different places. And so getting into family sessions, connecting people with resources, there's just a lot of complicated nuance in what we're doing when we're working with families, whether they're affirming or disaffirming. So my next slide is resources to learn more. So I'm going to pause briefly here and see if there were any questions about what we've covered in this section so far before we go over resources and I take any final general questions.
I think you're good to go ahead.
All righty. So some resources to learn more. I think that this is really helpful. So the first one is a free online PDF of a book called Counseling LGBTQ Adults Throughout the Lifespan. There is some focus on that emerging adulthood, which might be translated to adolescents if that's more the population you work with. But they have chapters focused on like almost any clinical issue that you can think of. And so I've uploaded these slides to TPN. Hopefully they'll be made available to y'all, but you can click through that link or you can just search the title of that book and find a free online PDF from the American Counseling Association. If you're looking for research to support your communication with families or parents, the Trevor Project is just an excellent resource. It's an LGBT specific suicide hotline and crisis hotline. They have chat, they have text, and they have phone calls, and they have like a quick exit for children who might not feel safe. I know that in our current context, there's a chance that they're going to lose a lot of their federal funding. My hope is that the services will continue. They also engage in a lot of research. And so I've linked to the research briefs specifically so that you can have access to some of the knowledge that they've acquired about how to support LGBTQ youth and like strategies that would be more effective for them. I've also linked to the Society for Sexual, Affectional, Intersex, and Gender Expansive Identities. This is SAGE. It's the LGBTQ plus counseling division of the American Counseling Association. And they have free competencies that were developed by robust teams, peer-reviewed, focused on counseling LGBTQ plus individuals. So they have standards of care for counseling sexual minority people, and then standards of care for counseling gender diverse, transgender, non-binary people. They also have standards of care for assessment with LGBTQ populations, which I think is a particular strength. There are some nuances to conducting assessments that get overlooked, and even research. If you're someone who's engaged in research or if you're doing grant-funded work where you collect data, that might be relevant to the work that you're doing as well. And then I know that not everybody has access to academic resources, but the literature is really important to cite as a source for why you do what you do and how. So I've linked to the Journal of LGBTQ plus Issues in Counseling. It's an academic journal run by SAGE, and it is now open access. So last year's issues and all future issues are made available for free without a university account, which might be very helpful. There's also the Psychology of Sexual Orientation and Gender Diversity. This is the American Psychological Association journal, and LGBT health is focused kind of on broader healthcare needs among LGBTQ plus individuals. There are probably a million more resources out there. I tried to pare this down to like the most salient and what I thought would help you the most moving forward. So that's what I have for you. I'm going to leave the slides up so that the closed captions stay up, but I would be delighted to take questions, comments, invite Deborah to add any closing remarks as well. And thank you all so much for being here. This is such an important topic during an important time, and it's so exciting that more than 600 of you wanted to learn about this today.
Yes, thank you, Jordan. This was incredible. We got so many good comments, supportive comments about just how useful the information is, and So just thank you for a wonderful presentation.
Thank y'all so much.
All right. We'll get to the questions now. First one's from Sheila. Is there any research on transgender and adoptive children? I know so many that experience this intersection.
Mm. There is so little research on transgender people in general. It's one of the biggest gaps that we still have in health research. And so I'm not familiar with any research that specifically looks at intersections with adoption. But I would not be surprised at all to hear that there is a large intersection there. And I can imagine that that would exacerbate mental health needs if you've already got the adoption trauma and then you're navigating the world that's hostile to your gender identity. So I'll do some follow up on that. I'm not sure, and this is such an under-researched area that we might not have as much data on that as we'd like, unfortunately.
All right, thank you. Um, Question from Marcella. Are more states denying marital status now?
Not yet. So we're in a tricky place with the marital status thing in that it is still federally recognized through Obergefell v. Hodges. That was the Supreme Court case that made same-gender marriage legal everywhere. Some states have put in provisions to allow individual county clerks to refuse to marry a same-gender person. And in that case, they just have to provide somebody else. There is some concern that there will be legal challenges to same-gender marriage. For example, there have been a couple states, including Idaho, that have passed like it's not quite a law, but they're basically saying like, please, Supreme Court, take this case back up. We think it was decided wrong. And so there's some concern that Obergefell will be overturned, but there is the Respect for Marriage Act that was passed bipartisanly in the last few years that basically says even if a state refuses to allow same-gender marriage there, they are legally required to recognize same-gender marriages that were performed in other states. So the current legal context looks like if Obergefell v. Hodges is overturned, the Respect for Marriage Act would require that a same-gender couple go to another state to get married where it's legal, but then their state would be required to recognize it. Now, there's always a chance that something like the Respect for Marriage Act is found unconstitutional if Obergefell v. Hodges is overturned. So it's a complicated answer. I don't know what it's going to look like. And the Supreme Court has not yet taken up that case. So we don't know if that's something that will fully be considered.
All right, thank you. We have a question from Gina. Do you think social media post-COVID has influenced these new identities? I see on TikTok and other platforms how there has been an increase in identities. Do you think that influence from others on social media is what is increasing numbers?
I do not. And I totally get how it could come across that way because like we see people talking to each other. But what most of the research supports is that this is actually has to do with greater social acceptance. And when we have greater social acceptance, we have less social stigma and people are more likely to come out and people are more likely to learn the language that describes why they feel othered. There are always cases where people think they might be queer or trans and then they aren't, and they either detransition or go kind of like, oh wait, I'm straight, like I was just figuring this out. It's very rare, but it happens. That does not mean that queer or trans identity is a phase, right? It means that some people are figuring themselves out and explore whether this is a part of it. I think where social media might have an influence is giving people access to that information so that they get a label that might fit for them earlier, rather than that it is leading people to over-identify as LGBT. And part of it is just like when we think about our current legal context, it is not a fun time to be a queer or a trans person. And so it's just very unlikely to me that people would expose themselves to that level of discrimination persistently when there's actually not as many social benefits as people think that there might be. So I think it actually has more to do with we're getting closer to the real prevalence. And this is also supported by research. So I don't know if folks have heard of the Kinsey scale, but in the 1950s, Alfred Kinsey was doing research on sexual attraction and found that the vast majority of people are not 100% straight or 100% gay, but there's much more variation. And particularly with men, like many more men had experienced sexual attraction to another man at some point or engaged in a sexual behavior than would have self-identified as gay. And so I think it's more the natural variation that we see in the population is just being better represented. But it's a good question. I get why people wonder that.
All right, thank you. And the last question, I believe, is from Erica. I work with LGBTQ folks with substance use disorders and negative experiences with Alcoholics Anonymous slash Narcotics Anonymous because of religious trauma history and refer them to alternatives to AA slash NA. What has been your clients' experiences in general?
Yeah, so I totally agree. These 12-step programs that are religiously affiliated are often unwelcoming places for LGBTQ folks. And again, we know queer and trans people can be religious, but AA and NA meetings are frequently held in religious contexts that aren't affirming. So even if someone is religious, an AA or NA program might not be a good fit. And frequently that's the only local resource, especially for rural communities. So I like the choice that you recommended, like choicesshare.org. I also really like Celebrate Recovery as at least a starting place that's a little bit different, a little bit less judgmental. And then often what I look for is if there is an LGBT rights organization, they'll frequently host recovery meetings of different kinds. So it's like more LGBT specific, or I might connect people with virtual LGBT specific recovery support group types of organizations, and that can be really, really helpful in lieu. But I think it's a really important point that our traditional approaches do not often work for LGBT people.
All right, thank you so much. It looks like you answered all the questions.
Awesome.
So, on behalf of the TPN Health team, I'd like to say a big thank you to Dr. Jordan Westcott. Just a reminder, attendees, in order to receive your CE certificate, you must complete the post-session evaluation that will be available in your TPN Health account within 24 hours after this session ends. Thank you all for attending.